patients. I am Sumit Madan. I take care of hematology team for Zydus Life Sciences Limited. On behalf of Mumbai Hematology Group and Zydus, I welcome each one of you for this webinar on all that one must know about high-risk myeloma. I also welcome the keynote speaker for the evening, Dr. Vinod from the city of Harley-Davidson, that is Milwaukee. Now to take these proceedings further and set the context, I welcome Dr. Subha Prakash Sanyal. Dr. Sanyal is a senior consultant hematologist associated with Fortis Hospital in Mumbai. He is a passionate clinician and a great academician. More than that, he is a great human being. He is very popular among his patients for his unique and caring method of practice. With this, I hand it over to Dr. Sanyal. Over to you, sir.
Thank you, Sumit. Just give me a minute. So good evening to all from Mumbai Hematology Group, and special introduction to Dr. Vinod. Yeah. So today's topic is all that you must know about high-risk myeloma from diagnosis to treatment. Our guest speaker will be Dr. Vinod Dakal from Milwaukee, USA, and it is total, the logistics and everything is totally taken care of by the Mumbai Hematology Group. It is supported by the Zydus and the Perfect Square, actually the company which will be helping us to get all the logistical support for this beautiful virtual meeting. So Mr. Ashish Kumar and his team from Zydus Cadila, Mr. Yash Kalpesh and the team Perfect Square, our entire executive committee of MHG, Mumbai Hematology Group, our guest speaker, Dr. Vinod Dakal from Milwaukee, USA. All our discussants will be joining as are either eminent hematologists or medical oncologists from the country, and your participations from sparing your Sunday evening. Thank you all. So tomorrow we have one more meeting, which is a very niche part of hematology, management of acute lymphoblastic leukemia in infants. Speaker will be Dr. Suma TL from Bangalore. Discussions are Dr. Sanjeevan Sharma, who will be the consultant hematologist, professor and head, medical division, Command Hospital, Lucknow. Dr. Rajan Kapoor, one more colonel, professor, Department of Medicine, consultant hematologist from Calcutta. Dr. Neeraj, clinical professor and HOD, Department of Clinical Hematology, Amrita Institute of Medical Sciences, Kochi, far south of the country. Dr. Rayaj, a hemato-oncologist and a bone marrow transplant specialist, Department of Hematology, Rajiv Gandhi Cancer Institute and Research Center, Rohini, New Delhi. Dr. Chandran Nair, professor and head, Department of Clinical Hematology, Medical Oncology, Malabar Cancer Center and Thalassery, Kerala. Dr. Dipankar Bhattacharya, associate consultant, Medical Oncology and Hematology, Medanta Hospital, Lucknow. Dr. Pankaj Tatia, consultant clinical hematologist, assistant professor, Department of Medical Oncology, Acharya Tulsi Regional Cancer Center, Bikaner. Dr. Asif Iqbal, from east of our country, Department of Medical Oncology, Dr. Bhuvaneshwar Bodua Cancer Institute, Guwahati, Assam. Dr. Sunit Lukwani, consultant hematologist, medical oncologist, Salvi Hospital, Jabalpur. So, guest speaker will be Dr. Vinod Dakal. So he is associate professor of medicine, division of hematology oncology, Medical College of Wisconsin, Milwaukee, USA. He has specialized in multiple myeloma and plasma cell dyscrasias. He graduated from Manipal College of Medical Sciences, Pokhran, Nepal in 2004, our neighboring country. He completed internal medicine residency at St. Francis Hospital, Evanston, Illinois, and a fellowship in the hematology oncology at the Medical College of Wisconsin, where he also served as a chief fellow. He has authors numerous publications, including journal articles, meeting abstracts, and book chapters. He has obtained his master's degree in clinical and translational science. His current research interests include multiple myeloma immunotherapy, focusing on the clinical and translational aspects, high-risk myeloma, and myeloma kidney disease. He is actively involved in several investigator-initiated and industry-sponsored clinical trials for patients with multiple myeloma. He holds membership of ASH. So now lecture, all that you must know about high-risk myeloma from diagnosis to treatment. Thank you, Dr. Binod. Now stage is yours.
Thank you. Okay, let me share the slide first. All right, here. Okay. Can you see my slide?
Yeah, we can see.
Thank you. Thank you, Dr. Sanyal. That was a very nice introduction. I thank everybody for inviting me to this meeting. This is my third time I'm giving a lecture, and I really enjoy the discussion and the participation. And this is a little bit difficult topic because, this is not much known out there in terms of uniform definition, and of course, in terms of the treatment, what to do. So there is a lot of work still needs to be done, and I will try my best, to compile some of the data in terms of how to diagnose patients with high-risk multiple myeloma, and what are the treatment modalities that are being done right now, and what are the ones that in the pipeline. One thing is for sure that if you look at the myeloma disease as a whole, we have made a very significant progress in the last 2 decades, but there are one subgroup of patients. There are a few subgroup of patients, I would say, that haven't derived the maximal benefit as compared to everybody or in general, and that is one of them is a high-risk multiple myeloma. So we're gonna talk about this entity, and then see what are the developments that have happened so far from the diagnosis, and what the new things that is coming up in this patient population. These are my disclosures. This is the audience knows quite well the evolution of multiple myeloma. Multiple myeloma is definitely not a single disease. It's a quite heterogeneous disease, and we all know it starts from a non-malignant plasma cell. With some unknown mechanisms, the plasma cell develops into a multiple myeloma, but it goes through a series of genetic changes, in particular the primary cytogenetic abnormalities and followed by the secondary cytogenetic abnormalities. As shown here, the primary cytogenetic abnormalities are mainly 2 types. One is the trisomies that is present in about 45% of patients, and then the translocations may involve in the immunoglobulin heavy chain gene in chromosome 14, that is IGH, and that is present in about 55% of patients. Now, if you look at the trisomies are mainly present due to the involvement of the odd number of chromosomes, 3, 5, 7, and as shown here, and then the translocations as listed here, as shown here, like 4, 14, 14, 16, 14, 20. Now, these are the primary cytogenetic abnormalities, and that must happen before that plasma cell becomes a malignant cell. And then with the time, again, with the reasons unknown, and with all the different factors involved, there occurs a secondary abnormalities, and the secondary abnormalities are as shown here. Some of the most common secondary abnormalities are chromosome 1q gain or amplification, and we all know the monosomies of 17 chromosome and deletion of 17p. In addition, there are a lot of recurrent mutations that happen, and these recurrent mutations are listed here. For example, the most common recurrent mutations are KRAS, NRAS, mutations of TP53 and 17p deleted chromosomes, and there are some other which is evolving, and we are trying to understand this more with the newer high throughput techniques. Mine is that it's not like a primary cytogenetic abnormalities are needed, but that is not enough for a plasma cell to become a malignant plasma cell. And with these changes happening over time, number of genetic changes occurs, and that makes this disease highly heterogeneous. Number one. Number two is that there is at initiation of the disease, there are multiple clones that try to take dominance. And at a certain time, there might be one clone, but over time, there might be alternating dominance of the clones. mainly because of pressure from the treatment or pressure from the environment or from the microenvironment. And that also gives rise to significant heterogeneity, not only at one point of time, but at different stages of the disease for each individual patient. So there is a quite heterogeneity. Even in a single patient, you will see this disease behaving differently at different points of time, and even at a single point of time. So this is one thing that needs to be understood before we go into decide and defining the high-risk disease. So what is the high-risk disease, and what is the definition we have so far? The most widely adopted definition is by this International Myeloma Working Group and by a staging called Revised International Staging System. So before the Revised International Staging System was adopted, the myeloma, the staging was done by what we call as International Staging System, or ISS staging, that incorporated only two factors. One is serum albumin, and the other one is serum beta-2 microglobulin. As you know, both of these factors, determine or take into account the disease burden. But as more studies came into existence, and they looked at the prognostic features, the prognostic characteristics that can impact the outcomes in patients, one of the most significant prognostic factors was found to be a disease risk by cytogenetics, or FISH. For example, patients with the translocation 414 behave completely different than the patients with trisomies, or even patients with translocation 1114. So given the impact of this cytogenetics on the disease prognosis, so International Myeloma Working Group study was published that took into account about 4,000 patients enrolled in different clinical trials and treated with modern therapy at that point of time. And they kind of looked at the impact of combined risk factors. For example, the patients were divided into three groups. One group is stage 1, that included patients with ISS stage 1 and normal cytogenetics. What I meant normal here is the standard cytogenetics and normal LDH, because there was a data that came out that's showing that LDH also has a prognostic impact on the outcome. Then the stage 3 was defined as ISS stage 3 and high-risk cytogenetics. So remember, there are only 3 high-risk cytogenetics that was defined in that study, because those are the ones that are most commonly utilized in most of the laboratory. One is 17p deletion, translocation 414, and translocation 1416. And we all know that these are the high-risk cytogenetic abnormalities. And the other group are patients with the higher level of LDH at the time of diagnosis. And based on that, the 3 groups were defined. And when they looked at the outcomes of these patients with these 3 different groups, as you can see here, RISS stage 1, the median overall survival is not reached in this study. Whereas compared to that, RISS stage 3 had a median overall survival of only 43 months. And when that staging was incorporated into other factors that could impact the prognosis of the patient, RISS has independent prognostic impact on both the overall survival and the progression-free survival. As you can see here, the hazard ratio is pretty high for patients with RISS stage 2 when compared to RISS stage 1, 3.68. And when 3 versus 1, even higher, there is a worse outcome in patients with RISS stage 3. So the current and most widely used adopted definition of the patients with the high-risk disease is those with RISS stage 3. That means the patients needed to have ISS stage 3 disease, so high disease burden, high-risk chromosomal abnormalities, one of that, or high LDH. Now, the question is how common and how inclusive is all this definition is. As you know, there are a lot of other high-risk chromosomal abnormalities, for example, chromosome 1q, MYC translocation, chromosome 1420, 1p deletion, those are not included here. So definitely there are a lot of other parameters that also impact the prognosis and can be included in the high-risk disease. Now we'll go into that a little bit detail. Now, what about the 17p? We all know 17p is a marker of bad outcome in all the diseases, and myeloma is an exception. So, but recent studies have looked that into a little bit more detail. And the way myeloma patients present, if you recall, when we talked about the primary cytogenetic abnormalities, patients could have translocation 414, which is one of the primary cytogenetic abnormalities. But at the same time, the secondary cytogenetic abnormality could be 1q or 17p. So what is the impact of that? And are all 17p the same? What is the impact of 17p with the TP53 mutation? So as you know, the P53 mutation, P53 gene is present in 17p arm of the chromosome 17. So what is the impact of that? So those kind of things were not known. In general, the idea is that all 17p are bad, and that could be true, but the further studies looked into that in a little bit more detail. So the study from the IFM in collaboration with the Celgene, and they looked at this the 17p at different levels of 17p, and what they found out is that actually not all 17p are the same. Patients who really do poorly are either those patients with the 17p chromosomes, deleted 17p, with a cancer clonal fraction of 0.55 and higher. So when you look at the 17p, how much is the fraction of the 17p are present in that cohort or in that sample? And if the fraction of that is 0.55 and higher, then that had a significant impact on the outcome compared to the patients with the cancer clonal fraction is less than 0.55. So this is a very important observation. The other important observation, what they found out is that other high-risk group are either that or those patients with the double hit. So for example, either you have 17p, mutated 17p with the 1q amplification or ISS stage 3, which is called a double hit myeloma, or patients with the biallelic inactivation of 17p, either by deletion of 17p at one arm or mutation and mutation in the other arm. So those are the ones who are the worst players. So that tells you that if you have incremental CCF change in 17p, means like if the CCF continues to go up, especially the cutoff is 0.55 and above, then that was associated with the shorter survival. You can see the confidence interval here. So survival is pretty poor in patients with a higher CCF, the cancer clonal fraction burden. So that tells you that not all 17p are same. Here you can see that the patients with the deleted 17p, but the cancer clonal fraction is less than equal to 0.55, they behave the same as patients non-deleted 17p. So this is an interesting observation that needs to be validated in more larger studies. Of course, in the study, they use both independent and validation cohort, and they kind of were able to demonstrate the results. But this is tells you that even within the 17p, there is a lot of heterogeneity that exists, and not all patients could behave at the same way as it is. Now, the other important study that came out again from the French group, and that was published in JCO, and this is a summary of that study in blood by Dr. Kaur, and that looked at the patients with concurrent cytogenetic abnormalities. So as we discussed before, RIS staging system is a little bit restrictive in a sense that they included only 3 high-risk abnormalities, and they didn't include, for example, let's say 1q or other abnormalities like trisomies, and what is the impact of that, especially if there is a concurrent abnormalities at the same time, and which is the one that is most frequently encountered in myeloma. So isolated cytogenetic abnormalities is not that quite common. Actually, it is a concurrent abnormality that is more common, that is more of a norm when you look at a FISH results of a patient with myeloma. Now, so this group looked at this large group of patients, and then they came up with a model where they found out there are mainly 5 cytogenetic abnormalities with a prognostic impact. So bottom line is that each abnormality had a weighted score versus just one single abnormality that what is done in RIS staging. In that, they were able to find out 5 different cytogenetic abnormalities with different weighted score. The most high-risk one were 17p, 414, 1q amplification, and 1p deletion. And then the favorable risk are trisomy 5. And then and the trisomy 21 was included in the high risk. So that weighted score was combined to a model, and that model divided the patients into 3 groups. And then this is the lowest risk group, and this is the highest risk group. And you can see the hazard ratio of mortality here. Patients in the high risk group is significantly worse outcome than compared to the low risk group. So this kind of model, this kind of a prognostic model is more relevant in the context that because you're going to seeing not only impact of one cytogenetic abnormalities, but other one, and also see, for example, somebody might present with the, let's say, trisomy 5, which is a favorable risk marker, and then you have a 17p patient, which is an unfavorable risk marker, but the impact of that 17p will get modified based on the presence of the trisomy 5. So the impact of one favorable risk marker will impact the negative outcome of the other marker, and the overall prognostic impact might be a little bit different than having an isolated abnormality. So as you go forward, these studies will shed light into more about the disease risk, and at the same time, what are the nuances that are present in each subgroup of those FISH and cytogenetics tests that we encounter and we obtain from the patient. But it's important to know that given the disease, given the nature of the myeloma, this kind of model will try to incorporate most of the factors that might be playing a role in deciding the outcome of the patients. Now, what are the 1Q abnormalities? So 1Q, if you look at the prevalence of the 1Q is one of the most common secondary cytogenetic abnormality. If you look at overall for newly diagnosed myeloma patient, they are present in about 1/3, at least 1/3 of the patients, almost up to 40%. And there is a lot of studies that are out there looking at the impact of the 1Q. So what happens in myeloma in 1Q is given by this diagram here. So this is a normal chromosome 1Q, and there is a 1Q12 that is very close to 1Q21. And this is some of the changes that happens. You could have abnormal distribution of chromosome 1 during mitosis, and that can give rise to trisomy of chromosome 1, and you have extra 1Q. And this is how you can see in the FISH. But at the same time, there's a decondensation of a heterochromatin of chromosome 1Q12. So those changes will lead into 4 different possibilities of the chromosome 1Q. One could be isochromosome 1Q, and as its structure is given here, and the FISH is similar like what is shown here. Then you could have jumping translocation of 1Q, mainly because of this decondensation at 1Q12 level. That could be jumping translocation, and the impact of that could be quite different. There could be tandem duplications of 1Q12 to 21. So they just duplicated of that region, and then it could have a combination of events. So you can see that even in 1Q chromosome abnormalities, you could have a lot of these things could be happening, but mainly for the sake of simplicity, they are divided into number of gains of the chromosome 1. And then what we have seen is that there could be, what you might have seen is there is an entity called 1Q gain, where they have more than 3 copies of one chromosome 1. And then the other one is 1Q amplification, where there is more than 4 copies. And the prognostic impact of these changes have been incorporated, have been studied in different by different groups. And this is the one study that came from the Arkansas group, where they looked at the impact of the chromosome 1Q, both 1Q amp and 1Q gain. So if you look at the overall prevalence of the chromosome 1Q gain, that is about 30%, 27 to 28% for newly diagnosed myeloma, and the 1Q amp can present about 9%. So the 1Q amp is definitely in a lower frequency than the 1Q gain. But if you look at the impact here, so this study showed that this is normal with no changes in the chromosome 1. So the chromosome 1, this gene is CKS1B gene, and then that is associated with that chromosome. And you can see that if you have chromosome 1Q gain, your survival is definitely worse, but not as worse as chromosome 1Q amplification. This is for the progression-free survival, and this is for the overall survival. Here you can see the 18-month estimate of the OS in patients with the 1Q amplification is pretty poor. It's 73% compared to those people with the no change in 1Q, or that gene is 90%. So that tells you that there is a difference in the impact of the chromosome 1Q, depending on whether it's a gain or amplification on the patient outcome. So this group study showed that. Bottom line is that 1Q changes could be a marker of the high-risk disease. Now, what about adding this 1Q to RISS? Because as we all know, RISS didn't include 1Q, which is one of the most common secondary genomic abnormalities. So this is the meta-analysis done from German and myeloma 11 trial from the UK, and also the Dutch study. And there were different studies that looked at the impact of 1Q gain and 1Q amplification, and then see if that adding to the RIS staging would impact the prognosis of the patient. So first is the meta-analysis here. As you can see, the gain is represented by this circle, and AMP is represented by the red circle. As you can see, the AMP has definitely a little bit worse survival than the gain, as shown here. But in terms of the hazard ratio is pretty much comparable, so that there are confidence intervals that overlap. So maybe not both are not widely different in terms of the prognosis. Both are probably bad. But what they showed is that if you add this RISS to the 1Q, you refine the prognostic impact even further. Patients who are RIS stage 2 or RIS stage 1, after adding the 1Q impact, their prognosis either upgraded or downgraded. And this is what the impact looks like here, as shown here, for both progression-free survival and overall survival. So bottom line is that what this study showed is that if you add 1Q definitely is a marker of a poor outcome. Both 1Q gain and 1Q amplification had an impact on the outcomes pretty much in a similar way. And adding that to RIS staging system even further refine the prognostic impact. So these kind of studies needs, of course, to be validated in other big independent cohorts and try to see whether we can add this the impact of the 1Q in our staging system to make it even better. Now, what about the gene expression profiling? So as you know, gene expression profiling has been used in myeloma for a long time. There are mainly two types of gene expression profiling that has been used most frequently. One is UAMS70 and the other one is SKY92. There are a lot of data from Arkansas that looked at the UAMS70 data that divide the patients to 7 different groups, and one, of course, the high-risk disease, and they have shown the impact or the independent prognostic impact of that gene expression profiling and the outcomes. Of course, this testing is not done that frequently or not done that usually, universally across the institutions. But that expression profiling did have impact on the outcome. Similarly, the same thing with SKY92. This is the 92 gene profile, and it does identify high-risk group. The size of that high-risk group varies from 15 to 30% depending on the testing used. And this is the recent study that looked at the impact of SKY92 along with the RISS. So similar to another study, because RISS is one that is most commonly adapted and most widely used. And so they try to do the impact of this SKY92 gene profile with RISS. And as you can see here, so here in the SKY92 as standard risk and high risk, and this is the RISS. And as you can see, when you combine that to the SKY92, the prognostic impact is divided into 3 different groups here. And this is the independent cohort where they looked at this, assessed the impact of this combination of this SKY92 with RISS. And then there is a validation cohort with the COMPASS data set. And this is from the Dutch study from the clinical trials. You see that the RISS with the SKY92 again refines the prognosis even better than just RISS itself, as same with the previous study with the 1Q, and that has been validated in the different cohort as well. So the bottom line is definitely adding the gene expression profiling data to the RISS makes or refines the prognosis. But it's just the limitation that the gene expression profiling is not that frequently used in all the centers. For example, at our center, we don't use gene expression profiling. In the standard we use is the FISH, for the most commonly used probes, including what is defined there in RISS and also the other cytogenetic abnormality. What about the impact of beyond genetics or beyond the FISH and cytogenetics or beyond molecular mutations? So this is the data that they looked at the impact of the extramedullary disease on the outcome. So this is the data from Arkansas, and they looked at the patients with the extramedullary disease at the time of diagnosis. And if you look at that, having extramedullary disease at the time of diagnosis definitely portends a poor outcome. So this is the patients treated, with the different therapy protocols, the total therapy protocols. And when they looked at those patients' extramedullary disease as compared to no extramedullary disease, they do very poorly, regardless of what the cytogenetics they have. And this has been validated into their number of other studies. For example, the patients who were not treated in the total therapy protocols, and the patient treated in the total therapy protocols, and they were treated on off protocol. And as you can see, in all the patients, whether you are treated with a specific regimen or not, you're having EMD or extramedullary disease prior to going to transplant or prior to any definite therapy, is a marker of the poor outcome, and they don't do very well regardless of the impact on cytogenetics. So this is an important parameter or a characteristic that needs to be taken into account when you define a patient with a high-risk disease. Now, what about the functional high risk? So a functional high risk means the patients who relapse very early after initial treatment. In particular, as you know, myeloma, mainly patients divided into transplant eligible patient, transplant ineligible patient. And what we see very clearly, those patients who relapse very early after transplant, they don't do well. So there are a number of studies. The first group that was to decide or to define that was from the Mayo group. And they looked at the patients, and those patients who relapse early, in particular, those patients who relapse less than 24 months after the transplant, they do very, very poorly. So this is the validation or the confirmation study. This is from the CIBMTR, pretty big data set. And when they looked at those patients, divided into two groups, one who relapsed less than 2 years and the other one who relapsed after 2 years. And then you can see those patients who relapsed less than 2 years, the overall survival is 32%, very, very poor compared to 80% who relapsed after 2 years, or who had no relapse at 2 years. Similar thing with that post-relapse survival, and patients who are relapsing early, even at the relapse, the post-relapse survival is pretty poor and significantly lower than the patients who relapse more than 24 months. This is another French study that looked at those patients and defined early relapse as relapse less than 18 months. And as you can see here, patients who relapse less than 18 months, similar to what was seen in the CIBMTI study, they do very, very poorly, significantly lower outcome or overall survival than compared to the patients who had no relapse at 18 months. And this is different groups of the patients in terms of the cytogenetics, and one of the things that comes up is what will happen, or what is the impact of the cytogenetics at the time of diagnosis. Does it matter when they relapse early versus late? In fact, that really doesn't matter. Of course, the patients who are standard risk cytogenetics and relapse early, high risk cytogenetics and relapse, not relapsing early, but if you can look at here, both do very, very poorly, whether they are standard risk cytogenetics or high risk cytogenetics. And we see that very quite common in the clinical practice. When you see a patient's an MRD negative response after the transplant and then relapse within 6 months, they do very, very poorly compared to patients who are high risk cytogenetics and not relapsing, within a year or within two years or something like that. So the time to relapse is a very significant prognostic marker, and patients who are relapsing early, in particular relapsing within 2 years after transplant, they represent a very high risk group. And this is very important that we need to talk about and then take into consideration when you manage these patients and decide the type of treatment. The other group that, of course, has a very high risk of outcomes is plasma cell leukemia. It may be a different entity, but this is, of course, the most aggressive form of myeloma. And we have seen that despite the progress made in myeloma therapeutics, the transplant, the outcome is still very, very poor. And this is the data that we did looking at the patients undergoing different transplant approaches in plasma cell leukemia in the modern era from in the last decade. And the patients here is one is allogeneic transplant, one is autologous transplant. As you can see here, this is a progression-free survival. This is the overall survival. Patients with plasma cell leukemia, despite the best treatment they could get, the outcome is pretty poor, and there is no difference in the outcome by the type of transplant. So even if you offer the best modality of the treatment and can get the patient to transplant, that really didn't change the outcome, including the patients who even went to allogeneic transplant. So the both modalities had pretty much the same. So these are the patients where definitely there is an unmet need for new and effective therapies and for better understanding of the disease. So this is definitely a high risk group. And now, as you know, the definition of plasma cell leukemia has more or less changed. It used to be more than 20% of the plasma cells in the peripheral blood. But now a number of studies have shown that the patients who have more than 5% of the plasma cells in the circulation in the peripheral blood do the same poorly as the patients with more than 20%. So now the definition has moved towards incorporating those patients with more than 5% plasma cells in the peripheral blood as a plasma cell leukemia as well. The bottom line is that one of the other risk marker that tells you the patient high risk is the presence of circulating plasma cells. So the patients, even with the less than 5% plasma cells in the peripheral blood, Uh, if they have circulating plasma cells, they do poorly and is a marker of a high-risk disease, even if they don't meet the criteria for the plasma cell leukemia. So this is another high-risk marker that needs to be taken into account beyond the cytogenetics and the fish. Now, the double hit myeloma. So the double hit and triple hit myeloma are relatively newer concepts. So double hit myeloma is mainly, in a simple language, it is defined by patients with the two high-risk chromosomal abnormalities. And this is one of the largest data set that looked into that. Is again coming from the Arkansas and MMRF combined database in newly diagnosed myeloma patients, with both adding both the genomic and the clinical variables, for example, age, ISS, and all those stuff. And with the recursive partitioning, they were divided into three different groups in terms of the risk profile. One is the low risk group, intermediate risk group, and the double hit group. So the double hit here is they looked at the patients with the double hit, and double hit is those patients with the biallelic inactivation of TP53. So those patients either have the 17p deletion and the p53 mutation in the other arm of the chromosome, and or 1q amplification, gain amplification with the ISS stage 3. So either of that is a double hit. And double hit, what they showed is that double hit has a pretty significantly worse outcome as compared to these other group patients, as shown here in both the PFS and the overall survival. As you can see, the median overall survival is about 20 months in these patients with double hit myeloma, which is what we see in the clinical practice if they have very high risk, ultra high risk myeloma. So these patients are ultra high risk myeloma. They behave very aggressively, and you give the treatment, they respond to the treatment, but they relapse very, very early, and then they become refractory to all the new agents and all the newer treatments, and the patients don't make that long. So these are definitely ultra high risk patients, where new therapies and the new kind of a mechanism acting drugs with mechanism action are needed. And the triple hit, if you have patients with the three high risk chromosome abnormalities, is very rare, but can represent a very high risk group as well. So as we starting to know more about the high risk entity, we also started to know more about the fact that the risk is not a static concept, or your patient walks into the door with a newly diagnosed myeloma, you assess a risk profile. That is not the be all and end all. That means there is a dynamic risk modality that happens with time. And we already see that in the patients, for example, the patients with the standard risk cytogenetics, or then get the best treatment, get the best outcome, but it relapse less than 6 months, they definitely are high risk. So it's more of a dynamic concept. And now, with MRD, minimal residual disease evolving as one of the important marker of the prognosis and response to treatment, the MRD is being looked at in patients with the different cytogenetic risks. So the first data comes, in a prospective data at least, comes from the patients from the IFM 2009 study. Just as a reminder, this is a phase 3 randomized study that divided the patients into early versus delayed transplant after VRD induction. So one group went to VRD induction and the transplant, and then went into RUD consolidation and then maintenance for 1 year. And the other group were delayed transplant. So they didn't go to transplant. They went to VRD initially for 6 cycles, then they went to maintenance after that, and then transplant 1 year to relapse. So in that, they looked at the MRD both by flow and the next generation sequencing at 10 to the power minus 6 level. So what they found out is that if you go to transplant, early transplant, your risk, your probability of achieving MRD negativity at the consolidation is about 10% higher than the patients who didn't go to early transplant. Okay, and they saw that MRD has a quite prognostic value here. So they are the patients who went to MRD negativity, and this is the patients who are MRD positivity at different stages of the disease. And you can see at all the time, the MRD negativity patients did better. So the red line is here, the red curve is the MRD negativity patients. Now, in addition, they went on to do subgroup analysis, and this is important observation here. So if you look at here, patients who went to MRD negativity, as long as they achieve MRD negativity, whether they achieve that by transplant modality or not without transplant, they did the same. So regardless of how you achieve that, if you achieve that endpoint, you're going to do the same. So this is a very important observation. Other observation, looking at the different cytogenetic risk group. For example, patients who are standard risk cytogenetics and high risk cytogenetics, they did the same. as long as they are MRD negativity. But patients who are MRD positive, they do poorly. Of course, patients with the high risk cytogenetic, if they are MRD positive, they do very, very poorly than patients who are standard cytogenetics. And then again, the same thing with not only cytogenetic, disease burden, this IS stage disease. If they are IS stage 1 or 3, it didn't matter. If you recall, the IS stage 3, RIS stage 3 really did poorly with the median PFS OS of about 43 months. But if you achieve MRD negativity with the treatment, it really didn't matter. Actually, they did the same as standard cytogenetics. I mean, the standard, the IS is 1. But if you do that, then you did poorly here. Of course, the stage 3 did very poorly if you are MRD positive than compared to stage 1 or 2. So these two observation or prospective observation that is seen in that IFM trial lay the foundation of the fact that MRD or the risk is a more or less a dynamic concept, it's not a static concept. Now, then this is now been looked at by different groups. This is the study, the previous was the French study. From the IFM study, this is the Spanish study, and looked at in their trial and look at the impact of the MRD on the outcomes, on especially impact of the MRD in the by risk status on the outcomes. So these are the patients who went to VRD for 6 cycles of induction transplant. They're randomized to either MEL or BU-MEL. They got consolidation VRD, and then they randomized into RD versus IRD maintenance, consolidation, and then maintenance for 3 years. And they looked at the MRD here. MRD is looked at by flow, is by next generation flow as compared to the IFM study, which is done by next generation sequencing, divided patients MRD positive and MRD negative. And if you're MRD negative, you could stop the maintenance. So this is that trial that looked at MRD and deciding to stop therapy based on MRD. Now, this is an important piece of observation, as you can look at it by risk profile. So these are the patients, the high risk cytogenetics. High risk cytogenetics as conventional way of defining the high risk cytogenetics. And this is the standard risk cytogenetics. And when we look at the patients with the high risk cytogenetics, you can see this is the patients with persistent MRD negativity. I mean, the MRD is 63% in high risk cytogenetics, and that is much higher than the patients with standard risk cytogenetics. Similarly, the proportion of patients achieving MRD negativity attend to different labels here. This is the overall, and it is 37%. So it's much lower than standard cytogenetics. So the bottom line is that by risk, there is a difference in the patients, number of patients that could achieve the MRD negativity, and that could vary from standard risk versus high risk. That is one observation. The second piece of observation is what we saw, similar to what is shown in the IFM study. So if you have MRD negativity, regardless of the cytogenetics, you are going to do the same. Both the group did the same. But if you're MRD positive and high risk, your outcome is definitely dismal than all groups. But if you have standard risk MRD positive, then your outcome is definitely a little bit better than high risk MRD positive, but not like MRD negativity high risk and MRD negative standard risk. Same observation for both PFS and OS, what is observed in IFM study that I mentioned before. Again, very important observation showing that the risk could be modified based on whether we can achieve MRD or no. Now, these authors went on to one more step and look at, is this different in the biology that kind of drives the MRD? Number one. Number two, if that is different in the biology that drives the proportion of patients achieving MRD negativity in high risk versus standard cytogenetics. So they did a number of experiments, number of additional throughput technology, bulk mRNA, single cell RNA sequencing to look at the behavior of the MRD clone that is present at each risk groups. For example, what they looked at, as we talked about these patients, they are persistent MRD negativity. They do very, very poorly. So there's standard risk patients MRD positivity, high risk patients MRD positivity. They did the FACS sorting and RNA-seq for these patients and whole exome sequencing for the patients. What they found out is the biology that drives the MRD, or the patients who are MRD positive in high risk, has a different biology than the patients with MRD negative. And here in high risk, you can see the different changes in the gene expression profiling. And more importantly, this is mediated by the ROS pathway, and that was not present in the standard risk, and this is what would stand out. So bottom line of this study is that the biology of the MRD clone in high risk is different than what is seen in the standard risk, and that is what is potentially driving the outcome that these patients have. But the fact that this MRD with the help potentially if that can be achieved, there is a hypothetical and advantage of these patients. If they can achieve the MRD negativity, they can have the same outcome as the patient with the standard risk MRD negative patients, and underscores the fact that this risk assessment tool can be modified as the patients go through different stages of the disease. So again, this is a summary of what we talked about. So risk is more or less now we're understanding the dynamic concept, especially with the incorporating the MRD status. Patients with the MRD negativity and all risk, they are the best outcomes, whether it's high or low. Patients with the MRD positive and high risk, they are the worst players, and MRD positive standard risk are in between. So this is something that is important piece of observation as MRD is being incorporated as endpoint in the clinical trial, number one. Number two, as a method to de-escalate the treatment, and then to decide what to do with this endpoint going forward. And then again, trying to see the prognostic impact, because we clearly see that the prognostic impact is clearly impacted with MRD in high-risk cytogenetics. So it really mattered a lot in these patients, the high-risk cytogenetics. And the future trial looking into that with MRD as an endpoint, and then with the actionable item will help us understand a little bit more. Now, what about other parameters or the other characteristics of myeloma patients, or the technology that could decide the prognosis of the patients? As you know, myeloma is a disease. There is a temporal heterogeneity, there's a spatial heterogeneity, and the bone involvement at different areas of the disease is an important hallmark. So how does that impact the prognosis? So this is the data that came out again from the IFM 2009 study. That actually study was such a rich study that tried to answer a lot of questions. And we talked about that, answering question about the role of MRD. And this is another looking at the role of PET and MRD in newly diagnosed myeloma patients. Again, this is a patients who are arm A is the patients on the RVD arm, no transplant, and then lane maintenance 1 year, and then arm B is the RVD arm with the transplant and lane maintenance. So these patients went on to answer two things in this study. This is IFM MAGM study, and one is which modality is sensitive in terms of detecting the myeloma lesions. Okay, number one, is PET or MRI? And number two, what is the impact of this imaging in terms of prognosis? So a PET and MRI was done at the time of diagnosis, then after 3 cycles of RVD and before maintenance. Now, what you see here is very interesting. The patients who are MRD positive by PET and not by MRI, their outcome is pretty poor. So that means PET has a prognostic impact on the outcome. Patients with MRD positivity after initial treatment probably may represent a high-risk group. And when they try to look at these patients in the status of the MRD, here MRD is looked into by flow cytometry. And what they found out is the best players are the patients with the PET negative and MRD negative. So those are the patients, they have the best outcome. So the patients who are MRD positive and the PET positive had the worst outcome. So it's important, given the nature of the disease, having MRD negativity may not only modify the risk of the patient. It is important to have the MRD negativity or imaging-based MRD negativity as well. And those prognostic impact of this PET as a modality to find the prognosis becomes important as you define the high-risk disease, and as you define to as you go on to define how to treat these patients to the best possible way. So this is an important piece of observation that was seen in that study, underscoring the impact of the significance of the PET as a prognostic marker in newly diagnosed myeloma after initial treatment. So if we summarize all what we had talked about, what we could conclude is that there is not a one definition that tells you how to define high-risk disease. There's multiple factors. Of course, RIS is the one that has been looked into large patient population, has been validated, with some other newer studies as well. But at the same time, there are a number of other factors that decide the prognosis and define the high-risk disease. We kind of went over some of them. Patients with the biallelic inactivation TP53, that is high risk. Genetic abnormalities, 1q, we talked about 1q gain and amplification. PET lesions, especially actually after treatment. Exploded disease, of course, is high risk. Plasma cell leukemia and circulating plasma cells are high risk. Old patients and renal failure patients, which we didn't discuss, was also considered high risk disease. Actually, as we age, there is a very nice study from the Arkansas group, and from that they looked at as you age, and if your frailty and ECOG performance status, driven by the frailty, kind of overcome the prognostic impact of the cytogenetics. So the frailty becomes a high risk marker as well in those patients. In addition to this, what is listed here, the other high risk features which talked about is, of course, the early relapse after transplant or after initial therapy. That is actually one of the most high risk marker, if you ask me, because I have not seen any patients who do well who are relapsing less than a year or less than 2 years after the transplant. That might change with a lot of new therapies coming in the pipeline, but at least in the current setting, they are definitely the most high risk patients. MRD positive patients, we saw that especially they are high risk cytogenetics, they have the most high risk disease and they do very poorly. And lastly, the double hit and triple hit. So they are the ultra high risk patients with the 2 high risk chromosomal abnormalities, sometimes 3 high risk chromosomal abnormalities. So this is all these things. So there is definitely the need of uniform definition of high risk, that you clearly can see that we need a uniform accepted definition, how to define these high risk patients. But there is a lot of heterogeneity and there is a lot of nuances when you talk about how to define a high risk patient. Okay. Now, what we have the tools to treat these high-risk patients. We all knew that these high-risk patients do poorly. They have their overall outcome, despite the treatment, is poor. So, what are the tools that we have? Now, this is the survival outcomes of high-risk patients before we have novel therapy. So, this is before 2010, when you have a VAD kind of therapy, and you look at these patients, different trials at that point of time. High-risk disease defined by 414, 17p. Again, not all high-risk patients were included, but if you look at this, the endpoint is 3-year, 4-year overall survival is pretty poor in these patients, despite the different therapies that are being used, including the modern therapies of bortezomib. So mean EFS, or the mean progressive survival in these patients, is in the ballpark of less than 30 months. So pretty poor. How about in the new modern treatment era setting? So this is the patients who are treated in the GEP-defined high risk based on the total therapy in Arkansas trial. And this data was presented, a decade ago, but it still holds true that even at that time, the patients who are genomically defined high risk, the GEP high risk patients, and they do very, very poorly. As you can see, this is 2003 and 2006 data in both the time. And despite the evolution of therapy, they did very, very poorly, with the median AFS again in the less than 30-month mark, and the 2-year estimate is pretty much comparable. So that means these patients continue to do poorly as defined by GEP high risk. Then in 2014 and 15 onwards, that kind of changed more or less the practice pattern of what we do in these patients after transplant. So as you know, most of the time the standard care at that time was a maintenance with lenalidomide as a single agent after transplant. But this study from the Emory group, that kind of a change, the results of the study kind of changed what we do for these patients. So they included 45 patients, all high risk disease, and high risk is defined by pretty broad here. The 17p deletion. 1p deletion was also included. 1p deletion is a very small number of patients. It definitely considered high risk, especially if this occurs in conjunction to 1q. There are other high risk. They also include the PCL, plasma cell leukemia, and other aggressive abnormalities. And this is the response rate after induction, after transplant, after response. What they did after transplant, they did a VRD maintenance or consolidation. Velcade weekly, 3 weeks on, 1 week of Revlimid and weekly dexamethasone for 3 years, and then later on changed to Revlimid maintenance once a year after that. So you can see the responses after induction, after transplant, and after maintenance. You can see with the use of RVD consolidation maintenance after transplant, their responses continues to get better and continues to get deeper. So that is an important observation. But what is more important is this one. You can see the overall survival, the 3-year overall survival for these patients were almost 93%. So that is pretty significant. So this again is a small study, single center study, could have a lot of different kind of limitations because of that. But this observation that the patients with the high risk chromosome abnormalities will have the one of the best possible outcome using the RBD consolidation maintenance kind of changed the paradigm of how we treated these patients at a point of time. So in general, the doublet maintenance, the PI and IMiD maintenance became a more or less a kind of accepted standard of care for these patients. Now, how about the other studies? So this is the one of the probably the largest trial that looked at the high risk enriched patient population in a cooperative group setting. This is called SWOG 1211 study that was published in Lancet Hematology last year. And they looked at, this is the design of the study, the patients with no upfront intent for transplant, but high risk chromosome abnormalities as defined by these parameters. The poor risk by GEP, so they use GEP in that study, translocation 1416, 1424, 1417P, all chromosome 1 abnormalities, again, AMP, LDH, and plasma cell leukemia. So this study included plasma cell leukemia as well. And they were randomized into arm A and arm B. In arm A, they go into RVD, and then arm B, they added elotuzumab as per the schedule that's given here. They go to induction for 8 cycles, maintenance for 28 cycles, and off protocol at progression and relapse. And this primary endpoint is PFS. And these patients had stem cell collected after cycle 2, and then ASCT allowed off protocol at progression and relapse. So these patients went into relapse, transplant only at the time of a relapse. Now, what the data show? The data show no difference. Addition of elotuzumab to RVD arm in a high-risk patient population didn't do any difference. So this is definitely a negative study. Progression-free survival, overall survival was no difference. But at the median follow-up of 53 months, as you can see there, RVD arm did equally same, maybe even better than the ELO RVD arm. So the median EFS or the median PFS of 34 months is pretty significant, and that is what has been observed in the prior study from the Emory group. So that tells you the potential benefit of IMiD and PI maintenance or continuation of this IMiD PI maintenance for these patients. Again, this is what suggested, this is not what the study looked at, but this is what this study suggested, a potential benefit of adding this IMiD and PI in these patients. Now, what about daratumumab? So daratumumab, as you know, is a very important treatment, agent for multiple myeloma, has been used in both relapsed and refractory setting, but it has not, of course, been tested as, high-risk enriched patient population. So this is a subgroup analysis of the studies that were looked at the impact of daratumumab on high-risk patients for both newly diagnosed and relapsed refractory patients. Use of daratumumab in the high-risk subgroup. Again, this is not this is a subgroup analysis study, but this is a meta-analysis looking into different studies. So as you know, Alzheimer's, Cassiopeia, Maya, these are for newly diagnosed myeloma patients. Alzheimer's, Maya is for transplant ineligible, and Cassiopeia is for transplant eligible. Again, this is a different heterogeneous patient population. And then here, relapsed refractory multiple myeloma, this is Candor, which is DKD versus KD. Castor and Pollux are for Castor is for DVD versus VD, and Pollux is DRD versus RD. And this combined when they did the overall meta-analysis using this study, they found that daratumumab favors the high-risk patients, is favored by daratumumab versus control arm, and here as well in the relapsed refractory patient population. So addition of daratumumab to the standard regimen at that studies did show there is a benefit of adding this in high-risk patient population. Again, that tells you that adding 3 drug is beneficial in this setting because this is mainly the comparison of 3 drug versus 2 drug for this, especially for the relapsed refractory setting. And then, but this monoclonal antibody could have impact on this patient population as well. What about the carfilzomib in high-risk patient population? So again, there is not one high-risk, enriched trial for carfilzomib in this patient. There are some of the studies that are looked into the high-risk subgroups. This is the single-center study from the University of Chicago, where they did KRD for 4 cycles, transplant KRD for 14 cycles, and then this is the high-risk definition based on their criteria. And high-risk was about 27 patients, and the PFS is about 57% at 5 years. Pretty impressive. Compared to what we observed before of median EFS of less than 30 months. And then there are 2 additional studies, and this is one study that looked at KRD for 4 cycles, similar to that, but KRD was given for 4 cycles. Then only 2 high-risk abnormalities, median PFS 11% at 5 years. definitely lower. So potentially, because of this, maybe this adding more KRD probably will fit. And then lastly is the randomized study of the Forte study, where there are 3 groups of patients: KRD 4 cycles transplant versus plus KRD 4 cycles consolidation versus KCD 4 cycles transplant, KCD 4 times consolidation, and KRD 12 cycles. So it is an arm without transplant, and this is how the high-risk definition was used. And these are different, kind of subgroups of the patients in terms of the proportion. As you can see that KRD transplant versus KCD transplant, KRD transplant is way better in the high-risk patient population. And similarly, KRD times 4 versus KRD times 12, KRD times 4 for transplant is better compared to no transplant approach. So this study definitely suggests that adding KRD and transplant is probably a better approach in high-risk patient population. Again, this is a subgroup analysis. It is not a high-risk in-risk trial. Now, what we looked at is we looked at patients. This is a study. This is the study that we did, which is on publication right now, which is just submitted for publication. We looked at the patients in the real-world setting. As we just discussed, based on the Emory experience, everybody is doing the IMiD PI maintenance in high-risk patients. But of course, it's not uniform. So there is a lot of heterogeneity in terms of, somebody does IMiD PI versus somebody does just IMiD maintenance only. And we looked at those patients who had IMiD and PI and compared them, or the way we looked at this study, that what is the impact of the bortezomib-based maintenance versus len alone-based maintenance in patients after transplant in high-risk myeloma. And interestingly, we found out, again, this is the data we presented recently, it's coming out soon in print and in paper. Patients with high-risk chromosome abnormalities actually did better with len only, both for 1Q and high-risk, both all high-risk compared to bortezomib. So it's a very interesting observation that we found out as compared to bortezomib-based. Again, this is a heterogeneous patient population. The high-risk definition is not uniform, and the bortezomib, could be combined with multiple other agents, but purely len alone is pretty much, maybe even better or maybe same. The bottom line is that doublet maintenance is probably not enough. These patients probably do need more than just PI and IMiD maintenance, more novel approaches to treat these patients. So these kind of studies will be important to design the future studies of what we need to target this patient population who, regardless of what you do, not that do very, very well. Now, this is one of the suggested approach that we can consider in patients with high-risk myeloma. Again, this is one potential approach that is more or less kind of people kind of adopt. Could be different across institutions. For again, we design the transplant eligible and transplant ineligible. Transplant eligibility, even if the patients, for eligible patients, we always recommend to get a transplant for patients with high risk. So KRD 4 cycles is done as an induction, but with the Griffin study, DERA-VRD 4 cycles is what used in most of the cases. That's what we do at our center. Then of course they go to stem cell mobilization and transplant. And then for after transplant, based on Emory experience and the SWOG study, IMiD PI maintenance. For patients who are transplant ineligible, they really cannot go to transplant. RV light or DRD, and then IMiD PI maintenance after RV light is someone suggested approach. Again, there is not much of data out there of what would be the best modality for these patients. Now, what about with the development of all this newer immunotherapy and incorporating that in high-risk myeloma? Now, we knew or we saw that patients with the MRD negative patients, and they do very well if they're high risk and they achieve MRD negative. They do very well, the same as standard risk MRD negative patients. So, can we use these new immune therapies, new immune combinations, and use MRD as an endpoint to eliminate the MRD in these patients? So, this is one of the suggested approach. Induction, transplant, and then look at MRD. And if they are MRD less than 10 to the power minus 5, or they are MRD negative by this in the standard criteria, they go to standard of care therapy as maintenance, whatever a standard maintenance is. If they're MRD more than 5, they go to experimental immunotherapy. It could be CAR T cell therapy, or it could be bispecific antibody. And then the goal is to convert this MRD negative, a positive to MRD negative as the primary endpoint. Similarly, the other approach could be you give quadruplet DARA-VRD kind of treatment for 4 to 6 cycles and look at MRD at this point. If the MRD negative to standard of care auto. So auto is still believing that auto is still a good modality of these patients. And if not MRD positive, then they can be randomized into two groups, transplant versus experimental immunotherapy. It could be again bispecific antibody or CAR T cell therapy. And the point is to convert the MRD positive to MRD negative, given the fact that MRD negativity means a lot in these patients with high risk chromosome abnormalities. Now, there are a number of trials that are being done right now looking into that. Number one is this is the trial that we enrolled, was open at our place, which is a KarMMa-4 trial, which is using CAR T cell therapy upfront. So this is a CAR T is ID cell, which is a ID capitation Viclucel. These are the newly diagnosed myeloma patients. High risk is defined again, is different based on the study. RIS stage 3 as defined by this. So this patient needs to have RIS stage 3 and they're enrolled. Cycle 1, they get initial induction with the triplet, whether KRD, VRD, or CyBO-D. Cycle 2, they will just get VRD or KRD. They don't get quadruplet. If they're getting quadruplet, in cycle 3, they don't get any dexamethasone. They go into leukapheresis, and then they go to stem cell T cell collection, and then go to get the CAR T product against BCMA. And the primary endpoint is, of course, safety, and this is the secondary efficacy. And then after day 90, the LEN maintenance is recommended. So that's we treated about 3 patients in this high-risk trial, and then the results are awaited at this point of time. But it's nice to see the high-risk in-risk trial being developed, especially using this immunotherapy upfront. Now, then there is another study called CARTITUDE-2 study. Again, we'll have a readout soon of this study, which is a BCMA-targeted agent, but not ide-cel, it's a Celta-cel. Which is the product from Janssen. And in this CARTITUDE is a basket kind of study. It is, the different subgroups are included. And here, one subgroup is patients with the high-risk cytogenetics, IS stage 3, high-risk disease and not intended for transplant. And they go on to induction. And then after that, apheresis. And then with that, they go on to Celta cell infusion. So this, again, subgroup study, but this is an enriched study that will help us decide whether using immunotherapy at early stage in these patients is going to benefit these patients and can give a long-term better outcomes. We are a part of this CTN 1901 study, which is still in the process. Again, high-risk disease patients, and then they go to initial systemic treatment and RIS stage 3, and they go to transplant, and then and after the transplant, they go on to CAR T cell infusion and go on to maintenance. So this study is being developed and mainly purely focusing on the high-risk patients. Now, the newer study that is a randomized study for the first time is again looking at the high-risk enriched patients, is being incorporating both bispecific antibody in the CAR T cell therapy, and this is the concept of the CTN SOS study. And first, what happens? These patients go on to DARA-VRD for 4 cycles. They go into transplant, and they're randomized into 3 arms. One is BCMA CAR T, in this case using BCMA CAR T using Celta-cel, and they go on to maintenance with the Revlimid and Velcade maintenance, and the MRD testing is done at different levels, and then the primary endpoint is MRD negativity, sustained MRD negativity at 1 year. Then the second arm will go into BCMA CAR T, followed by talquetamab maintenance. So talquetamab is one of the bispecific antibody targeting against GPRC5D, and then they go on to maintenance and looking at MRD negativity after 1 year. And last arm is a standard of care arm, which is what is in similar to Griffin arm. They will go to transplant, they go to 2 cycles of DARA-VRD maintenance, and they go to DARA-led maintenance for 1 year, and then MRD negative. So this trial is also being, is being worked on, purely focusing on the high-risk myeloma patients, and also using MRD as an endpoint. So both high-risk enriched and looking at MRD, which has a significant prognostic impact on these patients. And similarly, the SWOG is also designing a trial for patients who are no immediate upfront intent for transplant, high-risk disease, and then they are randomized to 2 arms. One is DARA-VRD for 8 cycles, and they go into DARA-VRD for progression, versus using DARA-VRD for anti-BCMA bispecific antibodies for 8 cycles. So as you know, these are the patients who cannot go to transplant. They are probably frail and they have a lot of other comorbidities, and may not be able to receive CAR T-cell therapy as an upfront modality and probably would benefit from the bispecific antibody. They go on to that, and then there are plus bispecific body till progress. And these studies are also in development right now. The bottom line is that there are a lot of high-risk enriched studies looking of using the immunotherapy and then using MRD as an endpoint to look at the impact of using to this in the overall outcome. And then lastly, this is the study called MASTER-2 study, which we are designing here at our center. It is a study looking not only for high-risk patients, for all comers, but using all these different combinations. It's and also using MRD as a primary endpoint tool to decide the therapy. For example, here we believed in the dynamic high risk strategy, like what we talked about before. Instead of looking at the high risk by cytogenetics, looking at the high risk by MRD. And so we give these patients of data-VRD for 6 cycles, and the patients who are MRD negativity after 6 cycles, they are kind of standard risk patients, and they are divided into, they can be randomized into data-VRD for 3 cycles or transplant. So you can, one arm may not need the transplant. That's what we believe. We kind of hypothesize in this one, and then they go into data-R for 13 cycles maintenance after transplant, and this MRD is done at different time points here, here, and here, and the primary endpoint is MRD negative, sustained MRD negativity at this time. Then the MRD more than 10 to the power minus 5, randomized to the functional high-risk patients or the dynamic high-risk patients. They are now, they are the patients who need more new therapies, incorporating immune therapies upfront. So these are the patients, then they are randomized to transplant, and then consolidation with the daratumumab teclistamab, which is a BCMA bispecific antibody, and then they go into maintenance with teclistamab for 13 cycles. And the other arm is a kind of a more or less standard arm, AHCT, then dara-R for 13 cycles, and maintenance of dara-R for 1 year, and then MRD negativity at 1 year, sustained MRD negativity at 1 year is the primary endpoint. So this trial is soon will open at our center, and we'll look into that aspect as well. So the conclusion, what I can say is that high risk multiple myeloma, if you look at based on the definition used, is about 10 to 30%. Is in general, if you incorporate just 3 abnormalities that you have with RISS, that might be 10 to 12%. But if you incorporate everything, it is about 30%. What we saw that is consensus is needed to define the high risk multiple myeloma, because it's important, because given the heterogeneity of the definition across different trials, it is very important to define and identify patients who are really high risk and could benefit from this novel new therapies. We saw that MRD negativity, the emerging endpoint, is very important, especially in patients with high-risk multiple myeloma. And we, for right now, we usually do transplant plus doublet maintenance in these patients, and if possible, trying to include them in the clinical trials with these combinations. In particular, we saw that there are a lot of studies that try to look at the role of CAR T-cell therapy, bispecific antibodies or T-cell engagers, particularly eradicating the MRD in those patients, and it goes without saying that we need a high risk enriched trials. So we need to include a multi-center cooperative group because this is again 10 to 30% of the patients, and you need a multi-center collaboration to design and successfully complete a high risk enriched trial, and then try to see if that patients can benefit from these newer therapies overall. And this is the end of my talk, and this is my acknowledgement to my team at Medical College of Wisconsin. And thank you so much, and happy to answer any questions.
Thank you, Dr. Vinod, for the very elaborate presentation. So I have just a couple of quick, and I'm just requesting to the discussion, please put your hand whenever you want to ask the questions. I will take the questions one by one. Just I start the context. I have two questions about, you talked extensively about 1Q gain and amplification. So I have two questions. Number one is a 1P deletion. When you see in the clinic the report of 1P deletion, how you plan that, whether you put in the high risk or but how you go about. And other than the 414 and 1416 translocation, so other IGH translocation abnormalities, how you rate them in your clinical practice?
Yeah. So as I mentioned before, 1P is also another high risk marker. It is not that very common as 1Q. It is present in about less than 5% of the patients, 5 to 6% of the patients. In general, they can co-occur with the 1Q abnormalities. And there are, again, studies are limited because they're not that common. But in general, the thought is that 1P is high risk, even more high risk if they include the 1Q and other abnormalities. So in my clinic, when I see 1P, I always treat them as a high risk chromosome abnormalities. And based on my experience, I can tell you they definitely behave high risk. Even just isolated 1P can be a very high risk marker. So I just treat them as a high risk, like other high risk markers that we talked about. It's just that it's small number, proportion wise, is not that very much as 1Q and other high risk. So I just didn't mention that, but definitely is a high risk marker. And the number two, what is the second question you said?
Second question, that other than the 414 and 1416, other IGH translocations, how you rate them?
Yeah. So in the IGH translocation, if you look at it, there are some are good and favorable risk IGH translocation, like 614 and 1114. They are definitely in the favorable risk group than compared to, let's say, 414, 1416, 1420. Again, 1416 is a very small number. 1420 is very small number. 414 is more common, about 14% of the patients, 10 to 14% of the patients. 1114 is used to be called a favorable risk marker, but there are a lot of real world studies, retrospective studies looking at that, and they're saying that they may not be standard risk as what we used to think. So maybe they are in between. They're not definitely high risk like 414 and 1416, but they are not same as 614. So they're in between probably. So I try to see those kind of things, but for now, except for 414, 1416, 1420, the remaining translocations I treat as a standard risk, and then I just do the len maintenance. And then for 1114, there is option of the venetoclax down the road, but initial treatment I just use len maintenance for those group, and remaining translocation I use doublet maintenance or the clinical trials.
Thank you. Dr. Dipankar, please go ahead your question.
So thank you, sir, for this excellent presentation. There's a case, sir. So there's a 68-year-old gentleman who presented with back pains and bone pains with a vertebral collapse in the past 2 months. So he was treated by orthopedician, and he came to me for the workup of myeloma. So we did a serum protein electrophoresis that showed a no M band. The free light chain showed a kappa of around 35 and a lambda of 6.8, and the ratio was 5.16. A PET scan was done that was showing a number of lytic lesions. So going by this bone lesions, we did a bone marrow aspiration and biopsy that shows 40% plasma cells. And on IHC, it was kappa more than lambda. So I also did a urine IFE and a urine protein electrophoresis that showed kappa chain in the immunofixation of urine. And so we started on this DARA with VRD. So with Darzalex and VRD, we gave 8 weeks of Darzalex. And then after that, again, when we repeat the free light chain assay, the kappa was 2630. So it was initially from 35 to 2630. So, sir, how would we evaluate this patient to differentiate between a disease progression versus a Darzalex-related increased kappa chain? Because clinically, the patient is fine. His bone pains and clinically, he's better. He's able to stand and walk right now after 2 months of therapy. But this kappa chain is showing an increase.
Did you repeat that kappa chain to make sure that this is progressing? I would do in that. So 2 things. One is, looks like clinically the patient looks like doing well, right?
Yes.
But biochemically the patient is, jump from 35 to 2,600, 500 is a huge jump. You don't see that, unless there is a real progression happening. Definitely, I'm concerned in this patient situation. Sometimes these patients, I have seen in few cases, data definitely doesn't give rise to increase in light chains. That is not going to happen. You might see a small spike of M protein because of DARA effect, but it's not going to change the light chain. The light chain burden is a very real burden. So one thing I want to make sure that this is true. So I just want to repeat in a week or repeat very in a short duration, make sure it's not gone up. So if it is still up, then there's definitely it's a progression. And you are giving DARA VRD, right?
Yes. So DARA VRD.
DARA VRD, and then you give 8 doses or 8 cycles. You said
8 weeks weekly for 8 doses.
So just two cycles, right? So two cycles. Two cycles of DARA VRD, and if light chain goes that up, then definitely a very high risk disease. So this is a primary refractory DARA VRD. I'm not sure why the patient's clinical is disproportionate to what you see in the light chains, but that jump is quite and kind of worrisome jump, and you don't see that with DARA effect at all. I will definitely make sure, repeat that number, make sure there is not a lab error, there's not a fluke, and then this is something that is going on with the patient. And if that is the case, then we'll change the treatment. You need to change the treatment. These patients definitely not going to do very well. If it's a primary refractory DARA VRD, I will change to KPD or some kind of regimen and then take him to transplant as soon as possible.
And yes, sir. So is there a need for bone marrow examination, or like we can do a IFE related to DARA-based IFE, so that at least
for light chains, no, not for the light chains. If the disease is like an M protein, then yes, it will, because it's IgG kappa monoclonal antibody, right, DARA. So you could impact that, but not that high. Also very small. It will have very small. The burden of that IFE will be very, very small. Number one. Number two, if with that light chain disease, I was asked, what is the cytogenetic of this patient? What is the FISH results?
Actually, sir, the FISH was not done initially. Only the bone marrow was done. The FISH sample was not sent because we were not thinking about this myeloma, but it came out to be 40% plasma cells. So that's why it was not sent.
Yeah. So if I will repeat the light chain, and then if there is a doubt, I'll do a bone marrow biopsy, and then try to do a FISH, and to make sure that is done. And then if that is true, this is true relapse or true progression, then this is not a good sign. You need to change the therapy, and then make sure that that they get other, because it's a primary refractory DARA VRD, which is not going to be good. Probably I will do some kind of KD paste or some kind of a a debulking therapy for these patients, and then try to take them to transplant right away. And the patients, hoping the patients are otherwise healthy, right? The patient is otherwise healthy.
He is healthy, sir. So like in this case, sir, like we are thinking about refractoriness to the anti-myeloma drugs, maybe the triple class refractoriness or whatever, like triple or quadruplet therapy refractoriness. So sir, how should we approach this type of patient? Because nowadays, a lot of new therapies are there, and like CAR T cells or BiTE therapies or cell mods, these are type of things are there. And sir, what should be the role of allogenic transplant in this, if we are thinking about it?
So yeah, that's a good question. I have a couple of those primary DARA refractory, DARA VR triple class refractory patients, even at like what you have. So what you have done in those cases is I have done PACE to get this directly to the transplant first, try to get them benefit of MEL, and try to contain the disease as much as you can. And then later on, since they're already triple class refractory, at least in the US, you have a benefit of clinical trial. You have the benefit of CAR T and bispecific antibodies. So my goal is to get them to as soon as possible to those trials. Of course, in India, it's not possible to get them to CAR and bispecific antibodies. So you can think of other things. At least what I would do for this guy, for this patient, for this kind of patients is debulk the disease with the chemo or other regimens, try to get them down, get them to MEL, benefit of MEL, and put them on, because you are already, Revlimid is not going to be helpful, Velcade is not going to be helpful. Probably put them in KR maintenance, KP maintenance, or something like that. Okay, number one. Number two, these are the patients. If they're young, yes, allo is something that you should discuss. If they're young and then can understand the risk that is associated with the allo, then you can discuss that. But again, as you know, allo is something that is a little bit tricky, is not really something that you want to do for all the patients, and you want to do in a place where there is experience, and then there is a resources, because there are a lot of complications that could be associated with that allo. But these are the kind of patients, if I have to discuss in setting where there is not a lot of clinical trial options, especially with the immunotherapeutic options, allo discussion is not unreasonable as well.
Can I ask another question?
Yeah, just I will give you a chance. Don't worry.
Okay, okay.
Dr. Sanjeevan, please.
Hey, Dr. Vinod, that was really a complete overview of high-risk myeloma, and I really enjoyed. So, I'm dealing rather with two strange, very rare, but they have happened in the last 2 months. Two patients, both of them gentlemen above 75 years of age. One with a 414 upfront, and one with the 1Q, isolated 1Q abnormality, no other cytogenetic abnormality found at diagnosis. So we counseled the family that both are above 75 and they had high risk cytogenetics and everything. But the family said, okay, let's give it a shot. So we gave them VRD induction. So surprise of surprise, both of them, they tolerated the therapy and they are now MRD negative at the end of 6 cycles of VRD. The issue is the PS is fantastic. Those guys don't have any comorbidities. They are absolutely now hale and hearty. Issue is that we know that upfront they had high-risk disease, both of them. Right now, maybe we are just going in that phase where the remission may be very short-lived because we know it was upfront.
Yeah.
So is this a case that we take them up with because of their age and a very good PS, if not for conventional 200 ml, but just, something like 140 ml, take them up for a ASCT and then put them on a double limit transplant, because this is something which otherwise by any conventional definition, they'll be called as transplant ineligible. So, but considering the high risk, is there a case in point to, take them for a, say 140 or a 150 ml and convince them to go ahead for it and then go for a.
So if this is the patient, if this is the patient in the US, I will definitely do what you said. VRD or DERA VRD followed by transplant. Okay. Because as you know, the age is the one that less than 65 is tested in the prospective transplant trials. But in the US, we don't have age bar, right? We do transplant for patients much older than that. And there's a lot of real world data. There's a recent paper from CIBMTI that looked at the patients over 75 years of age, and then they actually did well. So the last week I saw patients 79 and still very, very active, walks 2 to 3 miles a day. So I'm planning to get him to transplant. More so in patients like this, if the patient has a high risk disease, and kind of the problem is the patient has MRD negativity, but that is not what we are looking at. It's a short-term MRD negativity. They don't respond, they don't maintain that MRD negativity for long term. You want to have them sustain that MRD negativity for a long time, right? So I would definitely encourage, if there is no other organ limiting
there's absolutely none
comorbidities, then definitely I will do 140 ml. And then try to put them on, imid PI maintenance or something like that. But that's going to be my approach as well.
So thanks for just confirming the thought process which we had been.
No, that's excellent. Yeah, that's excellent.
Thanks so much.
Thank you, Dr. Sharma. One question from the audience: that how do you, Dr. Kannan, I guess, how do you manage patients presenting with renal failure?
Yeah, renal failure is definitely a big challenge. As you know, that is one of my interests in myeloma, and we have actually a clinical trial that trying to look at that. So if you look at the myeloma patients, about 30% of the patients will present with renal failure at different stages, and some patients could even present with dialysis. So that is definitely a kind of a challenging patient population, because they are they have bad outcome if you don't improve their kidney function. B, they are excluded from the clinical trials because they don't have this eligibility, reached and all this stuff. But what we have shown very clearly is that if you reverse the renal function, then their outcome is same as patients who have normal kidney function at the time of presentation. So the onus is on us to give the treatment as effective as possible to reverse the renal injury. Okay, and to that end, right now we have all good drugs, renally safe drugs that we can use. For example, we have a trial right now that we're looking at induction with the isatuximab, Velcade, Cytoxan, and dexamethasone at the time of the diagnosis. If they present renal failure, give for 4 or 5 cycles, then take them to transplant. And transplant is an important thing that we need to consider for these patients if they're eligible. Renal failure is not a contraindication to the transplant, including the patients with dialysis. So we have, we can do the patients, and it is surprisingly, you will see that some of the patients can recover the kidney function so much so that sometimes can come off dialysis after 3 months of treatment and even transplant. So it's important that you do that for these patients if they are eligible, number one. Number two, and the other thing that comes up is the role of plasmapheresis, especially in the patient in the high light chain, because we know that the light chain burden is the one that causes renal failure. And when somebody comes with a very bad kidney, light chain burden off the roof, then you want to think of the benefit of that. There are a lot of studies that looked into that, mainly from the real world, small retrospective studies. The prospective studies haven't proven the benefit of extracorporeal light chain removal, whether it be by dialysis or by plasmapheresis. What they have shown is that the time to initiation of the treatment is that what matters. If we start the treatment sooner, then that kind of can impact the renal recovery, and which ultimately impact the prognosis. So what I always tell my community doctors who send and call patients with the dialysis, patients who are bad renal failure, is don't even wait for bone marrow biopsy. Start high-dose Dex, Cytoxan, and Velcade. Twice a week of Velcade right away. And don't even wait for that. I think that approach reverses the renal failure in most of the patients. Of course, not all of the patients. Some patients, unfortunately, get dialysis. And that's my approach is we have a trial. So we're including those patients on the trial right now. But the good thing is that a lot of new therapies that are renally safe therapies are coming up in the pipeline. And that should probably would help us, salvage these patients. But they are definitely a very high risk and unmet need patient population. A lot of data is not out there.
There's another question from the chat box, that what you feel that will be the best cost-effective therapy for high-risk 17p deletion, 1q amplification, multiple myeloma after KPD?
So you after KPD,
yeah,
talking about at the time of newly diagnosed patients or relapsed?
Yeah,
patients?
newly diagnosed patients. Yes, is it India? Yeah, because pomalidomide is available quite freely, and I have also seen.
Oh, is it? Oh, yeah. Oh, that's
many
of course transplant is the most cost-effective therapy after KPD. After you give KPD, the goal is to, you saw that very clearly. So if you look at the Forte trial, it very clearly shows the Forte trial I mentioned before, KRD versus transplants versus plus KRD for 4 cycles, then KCD, transplant, KCD 4 cycles, KRD 12 cycles. Very clearly, KRD, transplant, KRD consolidation is the winner, especially for high-risk patients. Winner in 2 ways. One, it has a better PFS benefit. Number 2, it also has a better ability to sustain the MRD negativity. So this is a very important piece of information that needs to be incorporated when you talk about the role of transplant in high-risk patients. So if patient is transplant eligible, whether in the US or in India, or Nepal, wherever it is, in high-risk patients, my goal is to get them to transplant as early as possible. I don't tell them to wait. You can wait, maybe argue to wait for standard risk patients. That is, again, up for discussion for some other time. But high-risk patients, you have to encourage early transplant after initial induction, because that is the best modality out there so far that has been proven to deepen the response, to maintain the deep response, and to improve the outcomes. There is no question about that.
So same question I'm asking in a little different way. So suppose you have a high-risk disease you got for the transplantation, and now you plan for the maintenance. So all your patients in clinic get the same maintenance of the dual PI versus IMiD, or how you plan that? Or
so if, depending on what they got an induction. So if they're getting VRD, DERA VRD as induction, I usually put them in VR maintenance. If they got KRD as maintenance, I put them in KR maintenance. Depending on what they got as an initial induction. Sometimes we switch it, like I have switched it a couple of times. If their MRD is still positive after 1 year, I have switched to KR maintenance. So I've done that, but again, there is no data to guide any of those that. But especially for young high-risk patients, I usually check the MRD a little bit more frequently. I check the MRD and try to put them on doublet maintenance. Both KR or VR is equally acceptable, and depending on what they received as an induction, we can use that.
What is your comment about the DARA maintenance?
No, DARA maintenance it's again, we are looking into that right now in the clinical trials. But if you just go by what we have, the data is from the Griffin study, where the patients are randomized to DARA VRD transplant, DARA-VRD, consolidation, DARA maintenance versus, all those other maintenance. DARA maintenance, that DARA arm is winner all the way. I mean, in terms of the responses, MRD negativity, and all those stuff. Again, the survival benefit is not really seen out there. It's still a little bit too early, but PFS is trending towards in the favor of DARA arm. So you could argue that DARA maintenance is pretty good. Again, as a single agent, DARA maintenance is not valid. You would add Revlimid or something like that. But just the fact that it's a little bit it's depending on the provider to provider. We have been doing IMiD PI maintenance more for these high risk patients. That is a trend, is to use that. Once we see this data a little bit more, then I think we will start using DARA-R maintenance. We have 2 or 3 trials looking into that, and that subgroup analysis of that in high risk will shed more light into that. The other thing what we'll need to understand is also the results from the Cassiopeia study. If we look at the Cassiopeia study, which is DARA-VTD, then VTD, consolidation, DARA-VTD, VTD consolidation, and then transplant, of course, before the consolidation, and then maintenance DARA versus no maintenance observation. That in that group, it is very clearly shown that the patients who had received DARA as an upfront with the DARA-VTD arm, it's a 2 randomization. So after the consolidation, the patient randomized to DARA versus no DARA or no maintenance at all. Patients who benefited the most are the patients in maintenance arm, are the patients who had no DARA. So patients who had DARA arm didn't get maintenance, didn't get benefit with the maintenance. So maybe there is addition of Revlimid might help those patients, we don't know. But clearly the KR versus R maintenance, clearly in the Forte study, which randomized the patients with KR versus R maintenance, clearly benefits the KR doublet maintenance to the KR. So we have that data very clearly, both for PFS and for the responses. So I think, based on that and the doublet maintenance, possibly with the PI and IMiD is probably the one that we are doing right now. But again, that could change.
So do you believe in the fixed duration maintenance, or you just continue the maintenance till there is a progression or unacceptable side effects in your real life practice?
So to answer that question, there is an ASCO plenary coming up in like a week. I don't know how many of you are going to come to ASCO, but ASCO will have this plenary session with a trial called Determination Trial, which is one of the largest randomized study after IFM 2009, doing early versus delayed transplant with VRD induction. So the difference between that is in IFM original study, the len maintenance is given for only 1 year, but here the len maintenance is given till progression. I won't tell you the data because it's embargoed, but this is going to be interesting. That will hopefully answer the question. But to simple answer is I will do maintenance till progression. Okay, that is my philosophy to the patients. But patients, of course, may not be able to handle that all the time. So we have to decide based on the tolerance and all those stuff. But for doublet maintenance, about 2 to 3 years, first doublet maintenance, make sure they're handling it okay. And after that, I do single maintenance.
Thank you. Dr. Dipankar, your question, please.
So in the era of quadruplet therapy, so what would be the role of tandem transplant? Like any specific risk groups you would recommend to go for a tandem transplant? And so what would you choose, like a post-transplant consolidation with a chemotherapy or a tandem transplant? So when would you choose a chemotherapy post-transplant or a tandem transplant? Like which would you choose and when?
So both the modalities are dying modality in terms of in the US practice, if you will, So because in terms of tandem transplant, of course, in the Europe, we have this EMN study that looked at the role of tandem transplant in high-risk subgroups, the EMN H095 study. And as you know, that study showed the benefit of tandem transplant, especially in the high-risk group. But again, the context in the US is you have to look at is the study called Stamina study, where they looked at is one of the largest study that looked at the benefit of tandem transplant versus single transplant versus transplant followed by consolidation. That study showed there is no benefit of adding other thing besides the single agent maintenance. And so that is an important observation, and that kind of a change the practice pattern in the US. And then, so in general, the role of tandem transplant has more or less gone away. Okay. So I think I can send a text here, right? I can send a message here. or no? Can I send the message or no? Okay, here. So I'm going to send you the link of this one here. Did you get the message?
Yes.
Okay. So this is the practice guidelines that I kind of we wrote together. If you get that link, you can see the role of tandem transplant, the role of consolidation, and we kind of did with the ran Delphi method across actually international expert all over the world, and went over the data, and that clearly shows that there is not much of study out there, benefit out there of using tandem transplant and or consolidation. Having said that, a lot of these trials looked at the consolidation, especially the limited duration of chemo consolidation. So perhaps there is a benefit for patients who have a limited suboptimal response after the transplant. Maybe those are the patients might benefit from that. But in terms of large scale randomized studies, the role of consolidation, especially in the US setting, is not clearly defined. Now, again, going back to the EMN study, there is a consolidation arm called VRD consolidation versus no consolidation. There was a benefit of that arm with the VRD consolidation. But these patients never got VRD maintenance and induction or DERA VRD induction. So now if you are doing VRD or more commonly DERA VRD now, probably those modalities are not going to be that beneficial. So that's what I would say. Going forward, I think MRD and all those will help us decide whether these patients, like we talked about some of the trials, like master trial that we have, we're looking at MRD really to make a decision about whether these patients need a transplant versus no transplant. MRD in high risk, whether the patient is transplant plus additional something else. So those kind of studies will be more relevant going forward. But right now, I think if they are getting good induction, especially DERA VRD, even though the data is adding 2 cycles of consolidation with DERA VRD in the Griffin and the Cassiopeia and all this stuff, we usually don't do consolidation in the setting in the US in the clinical practice based on the results of the stamina.
Yeah. So one question from Mr. Dilip Bhai. Injection isatuximab is a next drug or better drug than daratumumab?
Same drug. I mean, DERA is definitely sub-Q. There is an advantage of using sub-Q, but in terms of efficacy, I don't think there is a difference. I mean, again, there's no head-to-head comparison, but there is for sure. If you relapse after DERA, the isatuximab doesn't work. That's for sure.
Dr. Afaq, please.
Thank you, sir, for this wonderful presentation. My question is regarding the management of myeloma with CNS involvement. How do you manage this subset of patients?
Oh, I think that's an excellent question. I was thinking of incorporating that one slide of CNS disease myeloma. This is completely high risk, completely, separately high risk group where they don't do very well. Again, the answer is not there. There is not much out there. Unfortunately, there is no disease, no drugs that really kind of penetrate the CNS and does the benefit. And of course, there is a drug like, IMiDs can have, pomalidomide could have CNS penetration, bendamustine could have CNS penetration, and drugs like selinexor, they say has a CNS penetration. There was a drug which was initially developed. We actually published that experience. There's a drug, newer PI called myeloma. And then that was, and now is not developed in anymore. We saw some kind of activity, and then we use that. But right now, I think the key is again try to see if the newer therapies can help these patients, like the CAR-T and all those can help these patients. Again, this is something an unmet need patient population. Where the overall prognosis is very, very poor. So I just send you that, if you can see that in the merizumab, but right now it is just, we really don't know how to manage this and how to, I mean, the CNS clearance will happen, and patients after that clearance, they can go into like other, effective therapies like CAR-T and bispecific. I think that's the goal to get them on.
Thank you.
So, Dr. Vinod, in your clinical protocol, how you place CAR-T and CAR-T particularly in the algorithm of your treatment?
So CAR-T right now is approved in the patients at the, commercially they are approved in the patients with the fifth line of therapy. That means they have exhausted everything and they don't have any other options left. Again, the subgroup of patients that could get that is very small, as you know, because they have already seen so many treatments, they may not be eligible to get that. But we have a lot of trials. We are very fortunate to have a lot of clinical trials at different stages of the disease. Even for the late relapses, we have trials right now. We have 3 or 4 CAR-T trials. The early relapses, few trials. We have trials for newly diagnosed myeloma patients with the CAR-T option. So goal is, given how good it is and given how effective it has shown in the relapse refractory setting, our goal is to get them into this, effective immunotherapies. But right now, as a standard of care, we cannot. We have to use at the late line.
Dr. Rayas?
Hi, Dr. Vinod. That was nice hearing to you. Just one thing, Dr. Vinod, how do you counsel your patients, or do you have any patients of myeloma whom you talk about operational cure? We talk about a lot of this newly diagnosed with high risk, a lot of therapies. Can we have a operational cure for myeloma? Some standard risk, some elderly guy walking into my clinic, VRD and guide through MRD. Can we have some set of patients? Do you really talk about operational cure? And if you talk that MRD negativity, do they agree? Means for getting MRD testing done every 2 to 3 months, and do they agree to that cure versus the procedure being done? Does this come into your clinical practice? We talk about this.
Yeah, not really. I mean, it's a thing that you look at, later on, and you look at these patients, say, okay, these are the patients who went to the standard therapies as compared to other patients, and now we have some patients going on 15 years, and then they are going fine. For those patients, it's kind of, they have achieved an operational cure or functional cure. You look, what you call that. But walking the patient front, I don't talk about the cure. I always tell them the realistic, the fact that this is incurable disease. And then there are some subgroup of patients who go on for 10 plus years, 15 years. We have patients to that, but there is no any kind of a tool there that will help us predict who is going to achieve that. As I said before, this very dynamic process, and then things could get different in different setting. But looking to answer the question of MRD, again, MRD is a tool that prognosticate how they're going to do, but we don't know what to do with the MRD, right? So I can tell you a very real world examples. There are some patients, those who were in the stamina study, they were 8 years on LEN maintenance, no evidence of disease, and they always have some side effects because LEN is not a very easy drug, diarrhea, fatigue, joint pains, and all those stuff. So they asked me, can I get off this? So I say, there is no data really that because again, the duration of maintenance is not also clearly defined, but as per the protocol, you can go on. And I always tell them, maybe we can do the MRD and see if you're MRD negativity, then there is a, maybe good reason to stop it. But again, it is backed by the data? Not really. We are investigating that. We actually did a master trial, which was published, and I think last year, where we used MRD to stop therapy completely. But we use MRD as 2 consecutive endpoints. But we know that is not enough. Patients who have 2 consecutive endpoints, whether 1 month apart, 2 months apart, could have MRD resurgence. It's a preface to relapse, either sooner or later. But it is possible that the patients may not relapse. They may have this low-level disease going on. So those patients who are mentioning about 15 years out, they are not MRD positive. You can see the clone there. You can see in the blood and the urine, but they are very low level. They are not doing anything. They are like MGUS state, like myeloma. So they may be having functional cure. So I think identifying those patients upfront with a very good technology, with the throughput techniques to see who are those patients and how these patients behave. Is it more or less dynamic risk profile that will happen with the change in the treatment, with the change in the microenvironment, with the immune system recovery, or it is something that is defined at priori at the time of diagnosis, that is just that you cannot identify right now with the existing technology. We don't know. So all these things, hopefully we'll be able to answer. More importantly, modulating the therapy, like with these new therapies coming up, you can even modulate. And can you change those patients from high risk, like MRD is one of that modulating factor. Is there any other factor that you can change? Can you target the immune microenvironment and change this patient's disease modulation to a level that you can control the disease even without therapy? And even if the patient has low level disease, so what? As long as it's not doing any problem, patients are going on with the rest of their life, their survival is same as other age mass control, then we are cured, right?
Thank you, Dr. Binod. I think we have exhausted all the questions. One thing I can tell you, your energy is amazing. You just talked 2 hours continuously. That is amazing. So when our MHG will start as an actual meeting, so we obviously love to be in Bombay very soon.
Yeah,
and,
I would love to come there. I have heard very good news about the group, and it's
yes.
I really enjoyed the discussion. It's all energy came from because talking to the patients.
You are simply amazing. I just appreciate that. So sincere thanks from the Mumbai Hematology Group. And as soon as you want to come, you are most welcome to this country and this city. Thanks all for the discussions, for the lovely questions. Kalpesh, your logistics are awesome. And ultimately the end of the meeting, I thank the Zydus, Sumit, for organizing this lovely platform to discuss a beautiful topic of high-risk multiple myeloma. Thank you all.
Take care.
Bye.
Bye.
Good night.